Well, it's 12 o'clock. We want to be sensitive to everybody's time on a beautiful Friday here, so we'll get going. Welcome, everybody, to this Minnesota Health Collaborative webinar on shared standards for medical clearance in emergency departments. We're really excited to share this important work with you and hope you gain takeaways that are useful in your own efforts with this work. So I'm Jody Dvorkin. I'm the moderator today and the ICSI convener for the Mental Health Acute Needs in the ED Working Group, along with my ICSI staff. And we're really excited to share the recommendations that have been developed. A few tips on Zoom functionality. It's quite user-friendly, but just if you need to adjust audio, go to the bottom left. If you want to change your view options, go up top. If you want to exit, it's on the bottom right. And questions will be Q&A, which we'll do at the end, and that's on the bottom. So feel free to let us know through the Q&A if you're having any problems. Great. And so let me start by introducing you to our presenters. We have two of our working group members of the Minnesota Health Collaborative Working Group, and we're excited to have them here and very grateful. So we have Dr. Bruce Sutor, who is one of the founding co-leaders of the working group, and Dr. Mike Schwemm, who is spearheaded the collaborative ED work on medical clearance. So our objectives today are up on the screen, but we hope to describe how the collaborative partners are creating and implementing shared standards for acute mental health needs in EDs and across the systems. Understand the need for improving medical clearance practices, and learn about the Minnesota Health Collaborative recommendations for for medical clearance in the EDs. So our main objective is to help you understand our call to action and have you hopefully participate when this webinar is done. And what we've tried to do is test, adopt, and spread Minnesota Health Collaborative recommendations to improve medical clearance practices in emergency departments. We ask that those working in many of the health systems we have on the line today participate in this effort, and certainly contact us after this webinar with any questions you might have. So on to just a few slides on the Minnesota Health Collaborative. Some of you might already have heard about the work, hopefully, but I'll just review it briefly. The Minnesota Health Collaborative started over 2 years ago and really started with a commitment from the CEOs of the participating organizations. They came together and envisioned a new generation of collaboration for Minnesota, where really we could come together to solve long-standing problems that each individual organization could not solve alone. The CEOs at that time chose to start with addressing the opioid epidemic and mental health. These are the members of the Minnesota Health Collaborative you see on the screen. 70% of the citizens in Minnesota are cared for and are provided insurance by the organizations in this effort. So I'll give you a second to look at the screen. ICSI serves as the backbone organization for the collaborative effort. At its core, the Minnesota Health Collaborative is about community. How do we do together things to improve care for our neighbors, our families, and our patients? And while this work starts within healthcare in Minnesota and with these partners, it will spread to those on this call, those beyond the call, and to our whole community. We need to engage with other sectors and other agencies, especially when it comes to topics like mental health and addiction, and we plan to do so as we move forward in this work. So we were charged to start with two broad areas, the opioid epidemic and mental health. And the CEOs asked subject matter experts from their organizations to further help us discern how to best scope these efforts and to determine how to create working groups to support the initiatives. We do have separate streams of work now for opioids and mental health, but we recognize that there's crossover, that these two areas overlap, and we plan to continue to investigate that intersection as we move further along in the work. The work and recommendations you will learn about today related to medical clearance are only one part of the package of recommendations that is in development to improve care and transitions for patients with mental health. And so we are happy to get information to you on the rest of the work whenever you need it. At this time, I'm going to turn things over to Dr. Bruce Sutor, who will talk more about kind of the situation where we are and why we really needed this effort.
Well, thank you for the opportunity to be here today and to share some of the work that we've done and learned. As Jody mentioned, we were tasked initially with identifying broadly what are the issues that are facing us in these organizations as it pertains to mental health. And I think all of the organizations that are mentioned there, as well as others, have really noticed a change in what's been happening in the emergency departments. And I really look at the influx of patients coming to the emergency department as a larger, really as a symptom of a much larger problem, which is that of the entire mental health care delivery system in the state of Minnesota and across the country not being adequate to meet people's needs. So as we started meeting and talking about what is it that we can tackle, we began by really looking at the broad problems that we're facing and then tried to think about how can we, as collaborative organizations, work together in identifying something that's within the locus of our control and then effecting some change. And we really hit upon the emergency department as the place for us to start, because what happens in an emergency department in terms of assessment and in terms of evaluating and managing people is something that is within the locus of our control. We can't control the issues that bring people to the emergency department, but it was something we thought we could do to improve care for people coming in. You know, imagine coming into the emergency department and having to wait there for a bed or for whatever the disposition is going to be, and you're there overnight, or 3 nights, or 5 nights, and in some rare instances longer than that. And we really wanted to see what we could do to improve the evaluation of folks in the emergency department, but also to figure out how can we work together to get this situation improved so people aren't necessarily stuck in emergency departments. So we really saw that there was an opportunity for us to be able to intervene on behalf of our patients within our systems, but also within the individual systems, but also potentially as a collaborative. We recognize that the concerns about assessment and our ability to assess people and to move them to the next place where they need to be can't be done individually, but really that as our organizations work together, we can improve things as a collaborative together. So we really wanted us to figure out how can we better identify where the problems are in terms of assessment in the emergency department that delay admission or delay moving on to that next step. And that was where we came across the idea of really looking at how can we systematize assessment, how can we minimize unnecessary and expensive laboratory work that stand in the way of people moving on. So again, we thought, again, that the emergency department would be a good place to start because we can make an impact not only on the patient experience, but also in the patient experience within the individual emergency department, but also across the system, and we hope learn some things that can be expanded across Minnesota and beyond. So again, we want to improve the emergency department experience, including transitions from the emergency department to other locations, including inpatient hospitalization. So what we wanted to do is develop shared standards using what the literature and our experience inform as the best practice in the emergency department in terms of assessment, treatment, intervention, and for transitioning to other facilities if need be. So similar to like other medical issues, for instance, acute chest pain, there are standards of assessment that are agreed upon in emergency medicine. And we wanted to take that concept of, are there things that can be done to standardize assessment in terms of suicide assessment, in terms of laboratory evaluation, what does the science say makes sense, and try to develop practices across our institutions that follow those guidelines. So the work that we've done so far, we began by identifying where we wanted to start working, which was in the emergency department. And then we started looking at how can we standardize medical clearance across all systems. We recognize that this idea of medical clearance oftentimes stands in the way of people moving to the level of care that they need. And oftentimes the, quote, medical clearance laboratories and assessments are largely unnecessary. We wanted to move on then to also standardizing not just how we medically evaluate people, but also can we standardize approaches for suicide screening and other factors that are affecting patients. If we can have a standardized assessment, whether one's in a small hospital, a large hospital, we can learn to trust that the assessment has been done reasonably and well if we know that people are meeting a certain standard, and thus helping transfers to occur. If I know as a receiving psychiatrist that a facility has done a standardized assessment that we've all agreed upon, I'm going to be more comfortable in accepting this patient. So we're also then wanting to move not just to evaluation, but our hope as we move forward is to now look at how can we provide more care in the emergency department, particularly for those who may be there for a longer period of time than what we have in the past. So moving from standardized assessment, trusting each other in terms of our ability to transfer, but when we can't transfer, trying to have standardized ways of assessing patients and caring for them. With that, I'll transition things over.
So medical clearance evaluation while in the ED. I should first talk a little bit about what medical clearance is and maybe what it isn't. So medical clearance for an ED patient who is presenting primarily with an acute behavioral mental health issue is the emergency department, emergency clinician trying to ensure that an acute medical issue is not either the driving force or coexistent with a mental health crisis, and also to reduce the chance of medical or physiologic decompensation should that patient need to be admitted to an inpatient mental health floor. This is always within reasonable certainty. We can never rule out anything 100% of the time, but we can certainly give it our best estimate. We relied heavily on assistance and expertise from multiple healthcare systems throughout Minnesota for this work. In addition, we leaned heavily on peer-reviewed evidence-based position statements that have been published through both American Association of Emergency Psychiatry and the American College of Emergency Physicians. These are collaborative efforts which were taken from landmark position papers that have been published in the last several years. We're not the only state that's going through these types of growing pains or this work. We should note that these recommendations never supersede clinician bedside judgment, and so these always have to be taken into account. They are guidelines, they are not rules. The goal of these statements is also to limit the preemptive, unfocused, or scattered screening tests, reduce waste, and to help streamline care for the patient. The goal is not to eliminate all testing, however. So imaging, monitoring, blood work for patients presenting to the ED may be necessary in certain circumstances. Point number one, for emergency department patients with primary psychiatric complaints, diagnostic evaluation should be directed by the patient's history and physical examination. This should go without saying, however, oftentimes routine laboratory testing are triggered. This tends to be wasteful and costly for the patient. Oftentimes, just sitting down, doing a thorough examination, paying attention to the patient's history, and you'll likely have your answer as to whether or not someone is truly medically cleared or not, without the need for ancillary tests. Recommendation number two is that routine, and by routine I mean blanketed, protocolized testing. Routine laboratory testing should not be required by facilities accepting patients with psychiatric treatment. There's an asterisk below there, however. So directed and broader clearance evaluations are definitely indicated for patients with toxic ingestions, known chronic complex medical issues such as liver failure, chronic renal disease, or for patients unable for whatever reason to participate in clearance examination. There's also a difference between mandated emergent lab testing and then courtesy lab testing, which could be added on at a later date. Courtesy labs are not obligatory, generally not helpful in the emergency management of the patient. They may benefit an inpatient facility. That may be therapeutic drug level testing, or other requests that would usually not be ordered from an emergency department setting. These are definitely different than the labs that we need to diagnose and rule out emergent medical conditions. We certainly don't want the courtesy labs to delay the acceptance of a patient. We also don't want lab testing to be used as a means to delay a potential admission or to perform lab testing preemptively in hopes of preventing a delay later on. And that is primarily the goal of this work. These are some high-risk groups that we need to pay attention to. And so this is by no means exhaustive or complete. I need to point out that delirium, especially under number 3 here, is a medical condition first and foremost. Delirium, ingestions, acute altered mental status without an obvious source, those need to be taken very seriously and need a very thorough workup. Those are medical issues first and foremost and need to be assessed before a mental health admission is considered. They're also high-risk populations, so new onset psychiatric symptoms over age 45, advanced age, age 65 or older, new cognitive defects, or a very rapid onset of an acute mental health condition at days as opposed to weeks or months. Fevers, cough, neck stiffness, we all know these things, but patients that are falling into any of these high-risk categories, toxic substance ingestion, withdrawal, exposure to drugs, altered mental state, abnormal vital signs, need to be handled a little bit differently. We do not want to be cutting corners in lab assessment. Something bad could potentially happen, and at very least, a thorough history physical exam, plus or minus labs or other testing are indicated in these cases. Urine drug screening, we understand there are strong feelings about this, and each system does have the ability to help guide their expectations between the ED and inpatient mental health facilities. The top bullet point here, when urine drug screening is obtained, it should not delay disposition. This is really important. It is very rare that the results of a urine drug screen, the rapid urine drug screen that most EDs have access to, is going to significantly change the disposition of a patient or the treatment while they're in the ED. The negative predictive value is great, provided that patient gives a reasonable sample. The positive predictive value, if you find that there's positive tests on a urine drug screen, is questionable at best, and so the overall accuracy is less than what patients are willing to own up to or what your clinical suspicion is. And so history and physical has greater than 90% sensitivity and specificity. Urine drug screen, the rapid urine drug screen test, can't approach that. Generally, if you ask patients, they'll tell you. Confirmatory urine drug screening, the more expansive test, is not a test that's generally available to most emergency departments. These are send-out tests that can take anywhere between 12 hours and several days to get back. And so it's not a very useful test while they're in the ED. We optimally would not hold people simply to obtain urine if they refuse to give a urine specimen. It's not a great use of the patient time unless there's something else that we need as far as a rule out, like a rule out for altered mental state from some unknown cause. For the middle bullet point, sobriety. So in patients presenting with alcohol intoxication, the recommendation is that the assessment be performed based on clinical rather than numerical sobriety. Numerical sobriety, 0.08 in the state of Minnesota, differs in some other states, is based on studies that were meant to assess for fine motor dexterity and reflex time in operating heavy machinery and motor vehicles. It is not meant to declare someone is capable of undergoing an acute psychiatric assessment. Clinical sobriety is more important, which might be, for certain people, less than 0.08. So someone needs to be awake, participating, and conversant. We should not hang on to someone until they are less than 0.08 just to start the assessment. Ability to participate is really key with all of this. And the bottom bullet, whatever direction your hospital chooses to go, it should be a collaborative effort between the ED and inpatient mental health facility. I often say that our most important tool that we have in the emergency department is a phone. If you ever don't know, call. If there's ever a disagreement between what should be done while in the ED, call. This is a provider-to-provider discussion, which is the best way to handle this. Preemptive testing on low-risk patients increases costs generally by several $100s for the emergency assessment, causes a lot of delays, and it provides very little value to the patient.
So this is really an exercise in change management, and I am fully aware that when changes come in medicine, there can be an extensive lag time, sometimes decades, before best practices are brought into place. And I think that for a lot of reasons that happens. I think that we get into patterns that we are used to. Systems develop their own, hospitals, individual units develop their own, they have their own history. People will sometimes want to have medical decision-making made on the one-off that happened 5 years ago. And so these are the things that really can affect change. I would say that for Rochester, for the Mayo system, I would argue that our experience with implementing this change has been a tale of two cities. It's the best of times, it's the worst of times. And in Mayo Rochester, I'll discuss the best of times and worst of times. So when it pertains to evaluations in the emergency department, for folks where we know that there is an inpatient bed in Rochester, things go very well. The teams know each other, trust each other. We actually have our psychiatry team evaluating all behavioral health patients in the emergency department. And so there's a good working relationship and trust there. So as we brought these recommendations forward internally, within Rochester itself, it worked well. And so we are, in those patients, we're able to draw fewer laboratory studies and actually move people more quickly across the street to the inpatient psychiatric unit because we're not waiting on a lab that we perhaps might have waited for before. So that's the tale of, that's the good side of things. The hard side of things, however, is as we have implemented this in our emergency departments, we've actually experienced that smaller hospitals, other hospital systems, may still be requiring the laboratory testing. And so what we found is that actually, from a pragmatic standpoint, can delay things even further because now we've done the assessment, we've made the determination, but the patient needs a bed somewhere else. That system may require their own set of laboratory studies that we haven't obtained. So now in order for them to consider us, consider our patients, we need to now get those. And so it's sort of a trade-off so for those we know that are going to be transferring internally, it saves time and money. For those that may need to go externally, it actually delays things a bit further because now we have to wait for laboratory studies that we didn't order and that in our estimation probably were not necessary. So the bottom line is that if you can't anticipate what other systems, other hospitals might want, and you don't do sort of a shotgun scatter, let's get these labs when the person hits the door so that we're ready to send them somewhere else, which we're not doing, it can cause some trouble. And that's why with this change management throughout the state that we know needs to happen, if we can get there, and I'm assuming our experience is probably not any different than what your system has and what other systems have experienced. If we can get to that level of trust with each other and not have these things, we can get away from that second problem that I discussed. Now, the issues that the other hospitals in our system are facing and what we have seen in smaller hospitals is that of the fear and concern, what happens if I don't have the medical coverage available that you have in Rochester, in Mayo, available to me in my smaller hospital, and I get something, our staff gets something that we can't handle medically because something's been missed. What I would argue about routine laboratory studies is I think they are a hope and a wish and a prayer that we had a magic test that would quote medically clear all the patients coming. And the reality is the yield on many of these tests in light that are just standardized, everyone must have this and this and this before they can come. The yield on these is so low that if one is relying on that as a receiving hospital to assure that this patient is medically clear, it's in my mind really a false. It's a false hope in something that doesn't bear any signal. Having a sodium level on a healthy 25-year-old is not going to be predictive of whether they've got a medical issue or not. It's the medical evaluation that happened in the emergency department that's going to be far better to inform that. So So it's one of the things that we see then is the role of the medical coverage and the fear of what if we get something that we can't handle and manage. And the other is it's the role of call. Oftentimes in smaller hospitals, particularly in rural areas, you might have a system where the psychiatrist is on 7 on, 7 off. And so then there's also this fear, and if you look back a few slides on, there was the clinician to clinician conversation. And implementing this, one of the fears is that if I am on 7 days straight and my unit doesn't feel comfortable and wants me to have the conversation with the emergency department, it doesn't take too many 2 or 3 o'clock in the morning phone calls to affect the quality of life for someone with the longer call scenario and more than what I might face as a psychiatrist on call in a larger system. And so that's I think another one of the fears that has resulted in delaying implementation in not just in our system, but in other systems.
Our experience from the Allina perspective has been similar. I should comment about our previous state before talking about our current. Our previous state was that we had a tendency to get preemptive labs and urine drug screens on any patient that might be presenting even remotely with an acute mental health need. The goal of this was to try to get ahead of the curve and not waste an hour or two later on in that patient's emergency department stay. No one likes to be in the emergency department, particularly for several hours to days. So if we could shave off a couple of hours in the back end of that by ordering some labs up front, we tried to do that. That was a learned behavior because of what Bruce just mentioned. We would get to the 11th hour, we are ready to go, and then the patient would get refused by the appropriate receiving facility simply because of the lack of labs. And so what happened was lots of inconsequential labs, maybe minimal lab abnormalities, a potassium that was just a shade low, a sodium level that was just a shade low, a urine drug screen positive for a drug that was not impacting the patient's acute presentation on that day. Or lots and lots of normal labs. And I don't think I need to tell everyone that just because your labs are normal doesn't mean they're free. There's still a significant patient charge for all these. And lots of labs sent on patients that were eventually discharged. And a lot of costs and complaints and frustration, a lot of blood draws that did not need to be done, a lot of urine drug screening tests that were negative when we already asked the patient about their drug use and they had denied everything. So some fractured trust because of that too. Since we started making a change a few years ago, we have been able to significantly decrease the use of our rapid drug screen tests. I think our decrease has been about 60 or 70% below what our previous number has been so far, and continues to go down. We still do need this test for certain presentations and conditions, but overall use for our entire department has dropped fairly dramatically. Comprehensive drug screens can be obtained at any point in time during an admission. It doesn't have to be while in the emergency department. Patients can give a urinalysis throughout their episode of care. We will frequently try to collect urine if a patient is willing to give us a specimen. If the inpatient facility wishes to add on comprehensive testing, they can be done at that time. But it takes roughly a day to get that back, and so it's less useful for us in the emergency department. In addition, our crisis evaluation timing has been largely based on clinical rather than lab sobriety, which is the recommendation of American College of Emergency Physicians. There are some patients that will get an assessment that clearly don't want to be in the hospital or are not interested in substance abuse treatment, wish to go home. In the past, when we forced them to stay until they were less than 0.08, we did precipitate some medically dangerous withdrawal in those individuals, and then we forced a medical admission that was probably never indicated all along if they did not wish to go to detox or get treatment for alcohol use. Blood alcohol measurements, serial breathalyzer use. This used to be something we did years ago. Someone would breathalyze every 2 or 3 hours. They get a blood alcohol level, another blood alcohol level 5 hours later. We've largely done away with that. In fact, if someone's already had or appears intoxicated and is willing to admit they're intoxicated, we may not test them at all. Also, we've reduced the preemptive labs. Like I said, this is another big win. We get labs when we medically need them. We obtain labs when the presenting chief complaint is not exactly clear, especially if someone has a history of dementia or cognitive decline, then it's absolutely mandatory. Complex medical issues, dialysis-dependent renal failure, poorly controlled insulin-dependent diabetes, end-stage liver disease, concurrent anticoagulation use, these are all definitely higher risk, as would be a sudden rapid deterioration over the course of days rather than weeks. And so we do still do extensive lab testing, EKGs, monitoring, imaging. We do all this stuff. We just do it in a much more focused basis that is more patient-centric. And patients, of course, always have the right to refuse this, provided they're able to make their own medical decisions. This has decreased cost, needle pokes, and forcing lab testing on someone who does not want it, that's already in a somewhat frustrated state by being in the emergency department in the middle of a mental health crisis, was a common time to have acts of violence outbursts and what we would call a code green. We've been able to reduce that fairly dramatically. To come, provider-to-provider discussions regarding add-on labs and assessment. We understand there's a lot of phone calls, a lot of interruptions, both from our inpatient psychiatry colleagues and in the emergency department. I think we do want we do want more communication between the departments. That's starting to occur at a greater rate now. I think that will continue to improve as time goes on.
Great, thank you, Bruce and Mike. So appreciate the examples and want to dive a little bit more into that and talk about some of the tensions in implementation and some kind of practical advice for our listeners on this webinar. So I'll start with this question. We talk a lot about trust. How do you practically start that conversation? So for organizations that have not started this work yet or really in quite the beginning of it, how did you get providers together to talk? Did you have any structures or committees created? What was the pathway to get started?
So we utilized our existing structures. We do have a behavioral health there's an emergency physician who is tasked with overseeing the behavioral health aspect of things. So even though psychiatry is embedded in the emergency department practice, we also have an emergency department physician who takes the lead role from a behavioral health standpoint in managing the ED. And so we really utilize that relationship. This emergency department physician understands mental health issues and the things that we're facing as psychiatrists, I would say more so than most emergency departments, emergency physicians, because it's just really been his passion. And so we actually were able to utilize that relationship with him in bringing this standard to the emergency department in Rochester and through our entire system. So I think that having a champion who understands the issue, and in particular, understanding the emergency department side of things as well as the psychiatry piece, really helped us. And we still have work to go, obviously, but it's really helping us to do that change management piece. And if you can bring the data, that's the extant data showing what is of value and what is not of value, is just really important. And that's why I think as we did our work, we really wanted to look at what are the standards out there. This wasn't what do we feel like doing, but as our work group worked on this, we went into the literature and looked for best practices and what is out there that makes sense. So I think that that having a change management champion or two, and really coming with the data and the information. The other piece of this is listening to the fears and concerns and acknowledging that I think the people in the receiving hospitals, and the receiving units who have the biggest change management piece of this need to be heard. And I think that listening piece of understanding what their concerns, fears, and worries are and trying to address those, not, if we approach this in a finger-pointing way, why aren't you doing this? We have these guidelines, not going to get very far, as opposed to understanding the local culture, the local concerns. So it's maybe more long-winded than you wanted, but that's my answer.
Yeah, building on what Bruce said, a lot of this is just communication and breaking down silos between departments. depending on where you work, it might be very rare, almost a never event, to have a voice conversation either in person or via phone with an inpatient psychiatrist who would be accepting that patient. And by and large, it still is not something we commonly do, but having a champion, having a liaison between the departments is absolutely crucial. So everyone understands where each other's pinch points are, pains and concerns. Like Bruce said, this should be an evidence-based approach. This is being done in other metros and states as well. We're not on our own with this. We're not in a medical environment where you can ignore best practice, best evidence, and be wasteful anymore. That creates delays that the ED just frankly doesn't have the resources to accommodate. There is always going to be the ability to have disagreements, but those disagreements should be sorted out via provider to provider, physician to physician, clinician to clinician, rather than blanketed shotgun labs, preemptive lab testing. Likewise, from an emergency department perspective, the onus is on us to make sure that our history and physical examination is complete. We're not missing something, that we are making certain the patient is safe to go to an inpatient facility. I think that's very important too. There's always room for improvement. I think we've come a long way from where we were a few years ago. More than any other patient type, patients presenting to the ED with an acute mental health crisis that need admission to the hospital have a tendency to get transferred outside of their healthcare system simply because that's maybe where the acute mental health bed is situated within the state. And so it is very helpful to have this be both multidisciplinary, but across healthcare system lines as well. Because Mayo has to work with Fairview, has to work with Allina, has to work with health partners in Essentia and Centricare, and everyone has to get along together. And that's really why we're having this talk.
And I just want one point of follow-up that I want to make in that is ask people to try to be as patient-centric as you can. Imagine you're in some sort of a crisis. Imagine you're destabilized or feeling poorly enough to wind up in an emergency department. And then are there for a prolonged period of time. I come into the hospital in Rochester to the emergency department. I might be there 2, 3, 4 hours. Now I might have to get in an ambulance and go up to the Twin Cities or to Duluth or Marshall. What is that experience like? And what does a delay of 3 or 4 hours mean to someone who's already destabilized? The emergency department is not the best place for stabilization of psychiatric patients. In fact, can be destabilizing with prolonged stays. And if there's anything that we can do to help improve that patient experience, whether it's in time or needle sticks or other things, I think really the better outcome we can expect from a mental health standpoint.
Fantastic. Thank you. And so I want to ask a few more things having to do with attention. So certainly there needs to be better provider to provider contact about a particular patient. And then Bruce, as you talked about change management within, the system, there's a lot of staff, right? All the ED staff and all the psychiatry staff that are involved in this process. How did you get them on board for this learned behavior? Rightfully so, people would be apprehensive to have less information, right, to keep the patient safe. So how did you, one, kind of handle changing this with the broader staff? And two, subsequent to the wins you've had, what have you learned from them?
So I would say that within the system in Rochester, what's been really helpful is having all the disciplines that are affected together at the table. This change affects nursing staff. It affects social work staff. It affects resident physicians. It affects our staff physicians. It affects all those disciplines, both in the emergency department and on the receiving end. And it's having those people together and having those conversations about how's this going to work? What concerns do you have? Is what was helpful with us. And those are as I think about the work that ICSI's doing, I think if we're going to do this change management, we have to figure out how to do this hospital to hospital. I would agree. We have to be able to work with Essentia. We have to be able to work with Allina. We have to be able to work with all of the systems. And if we trust them and they trust us, this is all going to go better.
I agree. I think looking at the utilization of resources in a more broad sense, it can be very eye-opening depending on where you're looking from. I think looking at the testing that has been done and what value add has come from that versus what cost both to the patient and to the healthcare community has been important too. So as we approach things in a more patient-centric, lean process, I think that we've come to some joint agreements between inpatient psychiatry and ED. There's still room to go. We still have to break down some barriers between healthcare systems as well, but building that trust is very important. And I think that there's a false sense of security, like Bruce mentioned, with blood testing. Blood testing in most patients doesn't give you much. It does in certain presentations. And someone presenting with delirium, obviously, it's a little bit different, but a patient presenting destabilized, like Bruce said, or with worsening depression, that blood testing is probably not going to add much. And we're trying to help trim some of those ancillary unnecessary delays in order for patients to get to the most appropriate place at the most appropriate time.
Great, thank you. And a final question about just implementation. I think there's a tension, and even hearing you talk, and do you embrace all of these recommendations, or recognizing there might be some resistance, particularly to a UDS or something else? Is there a staged approach? In your experience, there's no right or wrong, but what can we just talk about that? I think it's a big tension.
Yeah, I definitely think a staged approach is possible. From our perspective, I think from an ED perspective, we prefer to jump right in, but we also understand that may not be fully feasible. One potential staging would be to ensure that obtaining these labs, provided there's been a provider-to-provider discussion that would suggest that they're mandatory, does not delay the eventual disposition or acceptance to an inpatient unit. That would be a nice nice concession between the two groups. And then hopefully over time we can develop more evidence-based guidelines as to who will not require additional testing.
So it's outside of my area, and I don't know how long it has taken to develop the standards for evaluation of chest pain in the emergency department and come across agreed standards. My sense is it was probably years, and it probably still not uniformly followed. And I think that's the approach that we really need to take, is that I don't expect all systems, my own included, to just jump in with both feet and be really excited about this. But I think that if we can demonstrate that this is better for patients, better for patient care, better for emergency department flow, if we can demonstrate that, that's, I think, will help be compelling for the change that needs to come.
Great, thank you. So just for some next steps, you know, what ICSI is trying to help kind of as a backbone do is make sure we continue the cycle of learning and spread as we roll out these recommendations. So we start with early implementation, make some iterations, update the recommendations as needed, spread by other systems, continue to iterate, you get it, right? Keeps going and going. And so we need you, those of you on the call, and others as well, to give us feedback, to understand what your challenges are, what's going really well in your organizations, and how this works for you. And because this really does need to be kind of a state effort. These systems all work together. These patients are coming to several of the systems, and so everybody participating is what will make it work and move forward. So I'm going to pause and give a chance for those on the line to ask some questions. If you can ask them in the Q&A box, that would be great. And while we're waiting to see what pops up, I will kick off with one other question that I have more generally is, if you could talk about something unexpected that you've learned along the way in this work, whether it's kind of developing the recommendations as, you know, the collaborative, or implementing them. What's something that you wouldn't have expected?
In doing some literature research for this, I was really surprised to see that a lot of the evidence and statements that were made about the medical clearance guidelines were decades old. What Bruce mentioned earlier about how emergency departments approach chest pain evolved because of several things. One was a more accurate blood testing, so we had objective data that was much more accurate to rule out heart issues. The other was tens of thousands of patients worth of retrospective data showing the long-term safety of discharging low-risk patients and associated scoring systems based on comorbidities that could safely predict who's going to do just fine as an outpatient, as well as shared decision-making with the patients. And I think that's a big part of this too. That's lacking in medical clearance. There are certainly position pieces that are almost meta-analyses that are posted. That's about as good as we have right now, but there are not very, very firm guidelines posted right now. There are certainly some, and that's what we largely built off of. But a lot of the statements of these 10 tests are indicated for every acute mental health patient. They are very, very old and probably do not apply to most of our current patients right now.
My surprises would be how I knew there was going to be a lot of variation in the types of tests that people require or desire for hospitalization. I was surprised at how broad it was and how variable it is, and how impossible it is to do the shotgun approach of drawing labs when the person walks in the door, because they might need. I'm surprised at that. The other thing that surprised me is external to ICSI, how systems who have not been at the table or a part of it, how very resistant some of these systems have been. So we've got resistance within our system, but the resistance for people who are just getting introduced to this concept vicariously because of us has been strong, and which just tells me that there's a lot of work that needs to be done.
Great. And just a reminder to put your questions in the Q&A. And I have one more question that came from a member. We kind of asked some questions beforehand to find out what people wanted to know. And so it aligns with the resistance that you're talking about, Bruce. What would you say to the person listening on the line who's saying, I hear what you're saying. It all sounds really good. It sounds like the right thing to be doing. But I know my ED doc or I know my psychiatrist is going to do the learned behavior. I have brought it up before. They really just want to get that patient moving. They're going to do those routine labs, or they really want those labs when they receive them. I don't know what to do next because I have had those conversations.
Yeah, so someone's going to have to blink in the staring match. For better or worse, someone's going to have to just say, this is why I'm not going to do this test, because the evidence doesn't support it. And that is going to have to be a collaborative effort between your ED and your inpatient psychiatrists. At some point in time, someone's going to have to be the one to say enough is enough. So a champion, one from each department, I think would be strongly recommended. And if you can push that forward and develop some more dialogue between the sites, I think that'd be very beneficial in those situations.
My answer would be, if Dr. X or Hospital X it has their heels dug in on this particular patient that I want to have something done with, I'm pragmatic enough to know I'm not going to be able to change it right now in this phone conversation. But I think that then becomes grist for the mill for our organizations to try to talk at a future date.
Great, appreciate that. And I'll add one thing to the question as well. You know, the collaborative is this resource that we hope that external partners will use. So if you are struggling, reach out to us and we can hopefully have you benefit from the experience our providers have had, and they can share, have conversations with you to help you kind of get past that really tough starting point. So that's what we're here for. So please don't be afraid to reach out. This is not about reinventing the wheel, right? It's capitalizing on experiences of others, good and bad, learning from them and doing the work together to move forward. So I think with that, I'd like to conclude. You know, again, reach out to ICSI. We can connect you with the right people if you have more questions about the work, and look for more webinars to kind of understand more about where we're going next or what the iterations have been. We'll continue to put things on the website and to keep you up to date as much as possible.